TFCBT?
Just a little bit, yeah.
The bottom 5 o'clock.
Yeah.
And you'll do the first
Yeah,
5
you would.
o'clock?
I would think that you would use a very similar model. I mean, I haven't been PET trained or certified, but as far as
Yeah.
being very logical in its approach, I mean, what we're talking about, folks that have just tuned in, we're kind of talking about topics for presentations and demonstrations. So if you're an undergrad, this doesn't necessarily pertain, but hopefully it will as you learn about theories. But like with TFCBT, there's a model that it goes through, and this will be some repeat for Josh. I think we covered some of it in the other class. All I want is a new file. Just give me a new one. That's not new. Okay, here we go. So it gives you kind of a more comprehensive view of therapy. Like you know where you're going before you start, which was different than when I left the program. Is like I didn't really know where I was going when I started. It was like I have some techniques, I can try to apply them. So like the model starts with, and this is where I'm trying to go right now with us in this particular class with psychoeducation. I mean, my purpose for teaching us about the substances and about the brain is so that you, when you go out there and counsel, can also teach your clients about the brain and about the substances that they've been using. I mean, I think that's very important that people have a general understanding of what's happening. We can hopefully have a base of knowledge that all of us can operate from. So, psychoeducation in TFCBT, there's also an aspect of parenting skills. So if you have a child that's been through trauma, you'll also want to address appropriate parenting skills for those kids. R, and I think this goes hand in hand again with substance use. The R in the model is relaxation. So what we're going to spell out an acronym. So learning to implement relaxation with your clients is somewhat of a skill. If you're wanting to demonstrate that for this class, I'm more than happy to entertain that. I think that'd be a very appropriate exercise. I've had students that have done this, not even one-to-one, have done this with the whole class, like done a guided imagery or a deep breathing exercise. I've even had a student do yoga demonstration one time. So these type of things are appropriate to get comfortable with, because one of the things you'll see with the drugs that we're discussing, people are dealing with anxiety, very significant anxiety, not coping with chemicals that are flooding their bodies and their brains. So giving them alternative ways besides using substances, relaxing is very important. The A, I'll switch it up a little bit. This is kind of where feelings come in. You're thinking CBT, cognitive behavioral, and think, feel, do. Affect modulation. So being able to recognize when you're having a bad feeling or how to change a bad feeling. Being able to recognize when you're having a bad feeling. Mainly this is a lot of coping skills. You're really starting to teach people a lot of coping skills. And I would say, go ahead.
Is that like awareness when certain
It's awareness. I would say that it's awareness, and it's also, once you're aware, what do you do about it? What do you do when you feel yourself with a craving? If we're talking about substance use, if we're talking about trauma, what do we do when we start feeling like we're reliving a trauma or we're really anxious? One of the things about coping skills is rating feelings. So we'll get there. We're gonna cover this in detail, but what I'm doing is I'm going through one of the techniques with folks right now, so the graduate students can begin to think about. And if you haven't emailed me, I sent an email out to the graduate students to really come up with their topics that they're, we're getting along in the semester, and we need to really think about what you're going to do for your demonstration. So what I'm going to want you to do is demonstrate a technique, 5 to 10 minutes of one of the many evidence-based practices that we're going to cover. So coping skills would also go along with relaxation. C is actually cognitive coping. So if you think, I just can't do it, or I'm a worthless person, or bad things always happen to me. Some of those self-defeating, this is what some folks chose CBT for adults. This is really kind of where CBT for adults is located at. To a degree, but if you think about cognitive therapy, cognitive behavioral therapy, what kind of thoughts are bringing a person down, limiting their growth? And then if you're talking about TFCBT, this is really a good place to draw a line, because all of this stuff here counts to me when you leave the program. This is kind of counseling 101. You can really apply these things to a host of disorders. It doesn't just have to be trauma. It could be depression, could be anxiety, could be substance use. It's just good to have these in your tool belt. T, this is where it becomes specific, because we are talking about trauma-focused cognitive behavioral therapy. And this is where the exposure therapy comes in, where you actually have a client, and this is the hardest part of this therapy as well, but you actually have a client conduct and create a trauma narrative, being able to speak about their trauma, being able to speak about what's happened to them in a safe context, then destigmatizes that trauma. It takes the trauma from having power over them to them having power over that trauma. This is the crux of the therapy. The I is in vivo desensitization. It's basically taking that person to a place that reminds them of their trauma and working through it in real life. So it's real life practice. The C, the second C, is a conjoint session. That means that you're going to have a session with the child and a caregiver. And actually, these are going to happen throughout. They just have the fancy acronym practice so it fits there. But you're going to want to intersperse these conjoint sessions throughout. The big one comes after the narrative, and the child actually shares particular parts of their narrative with their caregiver. The E is enhancing future safety. So, enhancing future safety. One of the things that we know about people who have lived through traumas is they tend to get into situations that are unsafe, that the trauma many times occurs again, whether or not it's something that they're cognizant and aware of. We want to make them aware of that. We want to make them aware of being able to recognize what dangerous situations look like, be able to establish healthy boundaries with people, be able to put themselves in positions of safety. So this is what TFCBT looks like. So as I was telling Josh before we came on the air, it was, I wish that because I went to work with kids right after I graduated Northwestern, and I wish that I had this model day one, because it would have improved my practice and I would have done a lot better. I'm not saying that I did, horribly, but I would have been able to help people in a better way because I would have had a comprehensive understanding. When you're doing TFCBT, what it looks like at the beginning of therapy, what the middle of therapy looks like, and what the end of therapy looks like, and where your client should be. So anyway, a lot of times we get focused on teaching theory, whether it's CBT, whether it's Glasser and reality, whether it's Skinner and behaviorism, whether it's Freud and psychoanalytic. It's important to know those theorists, but when you're out in the field and you're practicing, this kind of thing puts the rubber to the road. It gives you tools that are actually going to help, and also a mindset where to go to once you're doing therapy, not just like I was, which was, okay, here's a client. Okay, what are we going to do with them? Here, I'm going to try this skill, this skill, this skill. And it was really just, and I would do some of these things. A lot of times I would do these things, but it was just haphazard. It was like, okay, I just kind of feel like I need to do that. And so this gives you kind of a grounding. And so hopefully a lot of the techniques that we'll cover in the second half of this course will give you, and that's really what I wanted to do for this course, because I really feel like substance use counseling, we can really have a concrete awareness of where we are and understanding of where we want to go and feel confident in what we're doing. So hopefully that's a good understanding of what we want to do. Hello, welcome to class. I see Alva out there. Let's see here. I see Kelsey and Chelsea. And I see Liz.
Yep.
And Jessica. I have Erica.
Right here.
Okay. And let's see here. I saw Cassie and Ashley out in Guyman. Hi, ladies.
Hi.
And then let's see here. Mario, are you Kevin? You guys out there in Woodward? Woodward, are uh-oh. I don't see anybody in Woodward. I don't think they could see us and hear us last time, so maybe they bailed out. Okay. Well, we'll go forward from here. I see Ponca. I got three folks holding it down. I got Rachel, Adam, and Justin holding it down. Ponca. Good to see y'all. All right, cool. Well, let's go ahead and jump into what we were going to jump into. So we're one class behind since I didn't put Labor Day in there, and let's talk about that. So I pulled up our syllabus, and you'll see the exam is supposed to be on the 21st, the first exam. I want to make sure we get a review, a good review before. Because we have covered a lot of information, so I want to make sure we have a good review of what will be on the exam, and prepare you guys to know what to study. So we'll probably get stages of change. I want to spend the whole time next time talking about the role of trauma and addiction. So that'll be on Wednesday. And if you can make it to class, make it to class. That's an important class. So we'll probably just roll stages of change down to here, and then do a review the last half of class next Monday. So I think I'm going to try to keep the exam on the same date.
So the 21st exam?
The 21st, yes. The 21st is the exam, which is a week from Wednesday. Okay, what else do we have? Would like to make a couple of announcements. Enid's Psychology Club is operational again, and so not that it wasn't, but they are meeting, and so the next meeting is going to be the 26th of September. That'll be here on the Enid campus, and we have a location at the boardroom. Okay, so we'll have a location set. Those interested in participating, please see me or Mrs. Kirby, and we'll set you straight where that'll be. And then also, for those of you that have paid attention the past few years, the past 3 years, mental health has seen, and substance use providers have seen cuts from the state. So if you're interested, you're going to go out in the field. I would highly encourage you to. There's going to be a candidate forum on the 28th of September here in Enid at Autry Technology Center. All the folks running for office will be there. John Innes, Chad Caldwell. There's let's see, his name is Pierce. Is the challenger there? Rhonda Harlow, Whitney Hall, and Peterson. They're the three candidates running for state house or state senate. Excuse me. They'll be there. So the sheriff's department will be represented. So it's from 7 o'clock that evening to 8:30, and so they'll be addressing mental health issues. And if you want to have a voice or want to at least hear the conversations, the more people that show up to this, the better, because if that's a packed room, both candidates that win are going to have that in their minds when they cast a ballot. When it comes down to does mental health and substance use get funded, they'll come to a realization, there was a room full of 200 people that in my community I probably shouldn't let down. I probably need to fight for this. So if you care about that, if you're passionate, please show up. That's the 28th of September. That's a Wednesday, and that's at 7 p.m. at Autry Tech. Okay. All right, I'm going to pull up. I had a student email me something, or not email me, but I think it was an email. This was going around Facebook. See if it. Nope, that wasn't it. So the
Hey, with
Ohio
the test-
police officers in Ohio put out this. I don't know if folks had seen this floating around Facebook. Had put out a photo. Apparently, this is a video. I was just looking for the. Oh, here it is.
I was saying the one with the parents.
So it's the one with the parents incapacitated, and there's a 4-year-old in the car seat. So, what are y'all's reaction if anybody saw that? What are folks' reaction to that?
Sure.
Okay, anger at the parents. What else?
I'm pretty irritated they didn't take the 4-year-old out first. That they took time to take a picture.
I know.
Yeah, that's pretty callous.
Picture does speak a million words. I mean,
Yeah. Other thoughts?
Wonder how long that was happening before the police showed up to take a picture, before some, random passerby took a picture.
Yeah. Yeah. How long has the kid been sitting in there? How long have the people been sitting in there? We're going to talk about how child trauma relates to substance use next week. We're going to talk about heroin this week. So that was the drug of choice in this particular picture. So I felt like we'll get a start for our topic with something kind of morbid like that.
I had a friend that would duct tape his supply to his chest so that when he passed out that his kids couldn't get to it. And he's like, oh, it's the smartest thing I've ever done. Like, is it the smartest thing you've ever done? He duct taped his, first it was his script bottle, and then it was the actual just liquid that he duct taped to his chest under his shirt. So that way when he passed out, nobody could get it.
That's called nodding off. They've nodded off in their phase of acute intoxication. So let's pull up opiates. Let me see if I can pull that up. I had a longer version that I cut down. Let's see here, Kevin. I see you. Is that you, Kevin, out in Woodward?
It is. I'm really sorry. I had a family emergency, and so I apologize for being late.
Oh, okay, that's all right. I just want to make sure I saw you coming in. Okay,
Yep, I'm
so
here.
So what do folks notice about, and never mind the Addiction Studies Advanced, you can tell I recycled my PowerPoint. What do people see about the, what strikes people about the photos?
Poppy seeds.
Poppy seeds. Why would I show poppy seeds in a class about opiates?
Because the poppy plant is the plant from which all opiates are derived.
We've known about opioids for a long
Thousands of
time.
years.
We've known about the medicinal properties. The Romans actually have documentation of using it. There's other cultures that have used opium and derivatives of the poppy plant for quite some time. And so, what do you notice about where the climate or the location, the geolocation of the poppy plants here? High elevation, yeah, kind of rocky, arid regions. Was the #1 export of Afghanistan. I assume it might still be. There was a commercial a long time ago that showed some people smoking marijuana, and this is actually over a decade old, with the anti-drug campaigns. It said, if you buy drugs, you might be supporting terrorism. Well, with marijuana, probably not, but with heroin, yeah, maybe so. Because, like I said, that is a big export crop of that particular region. So this is actually a picture of a poppy plant. What's going on with the bulb there?
The bulb is actually what they cut to drain the opium out of the poppy plant.
So you can see there that there's like been little razor blade slashes made, and so what seeps out, the gum is scraped off and then dried, and then that's raw opium. And so that in history, if you look at the way that the poppy plant's been abused, it's been abused probably through smoking opium a little bit more so. Of course, you have a lot different derivatives now since we've synthesized, the opioid propiates within it.
I know in the Roman days, didn't they used to actually make they called it milk of poppy. They made a tea out of the opium, and they would extract it and boil it down until it was concentrated, and then use it to be delivered orally as like an oral anesthesia.
Yeah, they've noticed the anesthetic properties for quite some time. Here's kind of a page from another textbook, and so this is from 1821. A guy had to first use opium to relieve the pain of toothache, and wrote that my pains had vanished, was now a trifle in my eyes. Here was the secret of happiness, that which philosophers had disputed for so many ages. At once discovered, happiness might now be brought for a penny and carried into the waistcoat pocket. Portable ecstasies might be corked up in a pint bottle, and peace of mind could be sent down by the mail. You'll see this is a Greek depiction of the goddess of night dispensing opium poppies. So there's a Roman physician named Galen, and Galen talks about giving away the poppy plant and different derivatives for dysentery. One of the things that we know that when people take pain pills is they get stopped up, they get constipated. So it probably was pretty good for dysentery. It's good for fever. Talked about bring fever down. So and obviously good for pain. Here's a picture of an opium den. You did see people in Paris and different areas where you would have these opium dens pop up and people would smoke. And I would say that kind of like we saw the people passed out there in the video, opium, if we smoked enough, would have a very similar effect. It crosses the blood-brain barrier and causes like a dreamlike state for the user. So this is a picture of a guinea pig's brain that they've administered opium to. What part of the brain would you say is most affected?
Frontal lobe.
Let me pick on Chelsea. What do you think? What's the part of the brain that's affected the most?
From opium?
Yeah.
Frontal lobe?
Based on that, and it's a guinea pig's brain, so it's a little bit smaller. So where is our cortex in relation to this and the guinea pig's cortex? Top or bottom?
I don't know.
Cortex is on top. Remember all the squiggly lines looked like they were like worms sitting on top of your head? And then the bottom of your brain, what's down there? Cerebellum, brainstem.
Yeah.
The main thing where opium is affecting this guinea pig's brain is down here in the lower part. So not so much with the thinking, cognitive part, but more the autonomic, think heartbeat, think digestion, think breathing. It's affecting those parts of the brain pretty significantly. As I mentioned, opium has been around for quite a while, and it started to be synthesized into morphine about the time of the Civil War, and about that time we also invented the hypodermic needle. So what you see here in this particular photo is a really old Civil War era hypodermic needle. Why would this be important for the Civil War?
Keep fighting.
Yeah, keep people fighting. There were some pretty gruesome injuries.
A lot of amputations.
Cannonball and buckshot and burns. Still today, if you go to the hospital and you have significant pain, what are they likely to give you?
Morphine.
Good stuff.
Morphine or something close to it. And did you know that heroin used to be legal? Like the Coca-Cola we discussed last week, heroin was once actually put out by the Bayer aspirin folks. There was Bayer heroin. So take that for pain. It says cough, and it is good for cough. It will tend to think about cough suppressants. Some of those derivatives were from opium originally. So the problem has been solved by glycoheroin Smith. It does suppress the coughing reflex. So there are a lot of different kinds of opiates.
You said it suppresses the coughing reflex?
It absolutely does.
What about,
so if you have,
sorry, go ahead.
no, go ahead.
So, what about like the gagging reflex? Because I know I've heard. Is that myself talking?
Sorry, you got some reverb.
Okay. What about the gag reflex? Does it affect that? Because I've heard like a lot of overdose to where they aren't on their side and they choke on their own throat.
So that's a good question. The overdose with heroin has more to do with suppression of respiration and heart. So with the gag reflex, one of the things that is interesting about withdrawal from heroin it's one of the most unpleasant experiences that, or morphine, or any, really, if you go any of the really high-powered opiates, it's one of the most unpleasant experiences that people can go through. You know, you think about how a person is feeling when they're high, no pain, relaxed, you know, basically on the edge of consciousness. Stopped up, constipated, you know, their bowels aren't working, not coughing. Then you look at what they're like when they come down. Think about the opposite of those things. One of the smells that, you know how smells really get in your memory? One of the smells that I'll never, ever, ever get out of my mind, and I'll want to, it makes me kind of sick to my stomach right now, is walking by the detox unit at the rehab where I used to work in Tulsa. So basically you have it coming out of all ends when a person is detoxing hardcore off of heroin. You have explosive diarrhea, you do have vomiting, which is interesting. You mentioned the gag reflex. People feel like, take your worst flu and multiply it by about times 10, the aches, the chills, the fever. It's a nasty, nasty experience.
Have you ever noticed, like, when they start detoxing, because I used to work at the jail in Tulsa County, they tend to get a lot of bad BO when they're detoxing, too.
Yeah, it comes out of the body, absolutely. Yeah, that sick, kind of rotten human smell. It's hard to get out of your. I'm sorry, it's a bad thing. It is not a good thing.
Delusions as well.
What's that?
Delusions.
Delusions. Yes, thank you for bringing that up. Not in reality.
Severe
Scratching,
depression.
severe itching. Yeah, depression.
And depression, I said depression, yeah.
Yes. So here's one of and this is important to know, is if you're counseling somebody that's coming down off of opiates, the withdrawal is not necessarily like alcohol where you're concerned about maybe being fatal. It's just the person is going to really go through hell. I mean, they're most generally going to make it through it, but they're not going to feel like they're going to make it through it, if that makes sense.
The part that really amazes me is it's kind of a thing of amnesia. You know, they go through this hell, and then before long they're back at it again, and you remind them of, hey, it was awful the first time. Do you really want to do this again? And they're like, oh, yeah, it wasn't that bad. No, I can do it.
The euphoria. Now remember our dopamine discussion. That's a good point. I'm glad you brought that up. Remember our dopamine discussion and methamphetamine and cocaine. I'm not going to go into the details of the neurotransmission of opiates, but they are roughly the same. If you take the dopamine aspect of the cocaine and methamphetamine, but knock out the adrenaline, people get really high on this stuff. Really, that feeling of euphoria. It's no less. I would say it's no less addictive than meth or cocaine because of the levels of dopamine that get released in the brain. Now it looks different because the other parts of the drug are really slowing your body down. Especially drugs like heroin. Really the difference between heroin and morphine. Heroin crosses what's called the blood-brain barrier and causes some delusions and causes some like daydreams and called nodding off, and people are in this fantasy type of world. But morphine, a person kind of does that, but not to the same degree, because there is this thing called the blood-brain barrier, and it doesn't pass freely. The molecules involved in morphine are somewhat different. So it's not this, it's going to sedate somebody, it's going to make them not feel pain, but it's not going to make them trip out, if that, in layman terms, makes sense. So here's the different kinds. Methadone. Anybody know what methadone is?
It's kind of like a supplement you're supposed to be taking, because my brother actually takes methadone, and he takes, I don't know, it's the way he explained it to me is kind of like a drug that he takes to try to get off drugs, basically.
I believe it actually was developed by the military to help soldiers who were returning from Vietnam and other places where they had gotten hooked on heroin. It like blocks all of the receptor sites that heroin attaches to and makes it so that heroin is no longer effective. But from what I understand, it has such a long half-life, it actually makes people like super addicts. And so the withdrawal symptoms from methadone are longer and more pronounced even than those from heroin, which only lasts 4 or 5 days. Methadone can take like a month to finish withdrawing from.
It is kind of a controversial thing. It is given as a substitute for people that are trying to come off of heroin. It's called medically assisted treatment, MAT. As I mentioned before, there's some others out there. We'll get to those towards the end of the PowerPoint. It's not necessarily going to be something that people. I guess people have kind of sought it out, but it doesn't have the dopamine release. In other words, the person's not going to get that high. The illusion that or alluded to, it does kind of block it. It attaches to the same receptor, to where a person who takes heroin, it's going to not attach. One of the difficult things about the opiates, and I said we'd mention overdose this week a little bit. It's really it's kind of a tricky thing. They've done studies. So I'm going to talk about tolerance for just a second. What is a tolerance? Let me ask Ashley out there in Guyman. Ashley, what's a tolerance?
You're like building up the amount you need to feel a high. So your tolerance will keep getting higher the more you do it.
Absolutely. Good description. Very concise. So you need more to feel it. So they've done studies, and they've studied people taking morphine, heroin, the opiates. And so let's say I needed 1 gram at home to kind of get high. And so I inject myself with 1 gram, and now I'm nodding off. And so I do that, and you get a rapid tolerance too. Anybody who's taken pain medicine knows that you do get a rapid tolerance to pain medication. So a couple of weeks go by, and I'm not feeling it. So I'm going to up my dose to 2 grams or whatever. And so they say, yeah, that's going to go on, in a person, because we talked about effective dose and lethal dose last week. Now, if you take that person and you put them in a car, say, an environment that they're not used to, that they've not done this in, this will blow your mind, but I'll show you the studies. The tolerance depends on the environment in which you're doing the drug. Because if you go to a novel environment and do the same amount, say I do the 2 grams now, boom, like I did the 1 again. In a new environment. That sounds like a made-up BS story, and it's not.
So last year, I took a learning class, and she said the same thing. Her mom was in drug abuse counseling and stuff. And she said that there are cues.
Yes.
Kind of like classical conditioning and stuff. The cues of the room make your heart rate either lower or higher, whatever you're taking, to reverse that. And then so when they go to a hotel party or wherever they're going, the smart people over to the because their body cue.
Yes, very good. So you heard the study. She's heard the study. It is the behavioral cues that get your body, your physiological body to expect a certain thing to happen. And then if you remove all those, boom. So my theory on that, I'm glad you said that. My theory on the folks that are in the car, not to give them any pass, but my theory is they probably hadn't done it in the car like that, and it was a novel environment, and their bodies weren't used to the same dose that they had acquired, because it didn't look like the first time. but then they are laid out. It's a strange substance, and a person can overdose without intentionally doing it. Dilaudid, Demerol, codeine. Codeine with cough, codeine in your cough syrup, yeah, it's helping suppress your cough. Lortabs, oxycodone, oxycontin. There are others. There's a lot of opioids out there. So here's the high. If you guys had that wave illustration that I've been going for, without all the clapping and then the tires burning out. The intoxication effects are. Let's see here. Honka, how about Rachel? Do you mind reading maybe the first three of those?
How do you say that first one?
Analgesia.
Analgesia? Is that what you said?
Yeah, analgesia.
Euphoria and sedation.
Yeah, analgesia, pain relief. Euphoria, you feel high. Sedation, you're kind of knocked out. What else? Let's see here. Jessica, help us out a little bit more.
Depression of respiration, additive effect with alcohol or barbiturates overdose. Depression of cough, pulmonary constriction, nausea and vomiting, constipation, dehydration, and then rheolysys histamine.
Yes, causes itching and asthma. Yes. So pupillary constriction, when this particular Ohio police unit released that, one of the press releases said pinpoint pupils, and that's one of the things that your body's shutting down, and so think about your eyes shutting down too. Your eyes are like going to sleep, so they're closing the black part of your eyes they're like really like pin drops, and that's a telltale sign that somebody is high in opiates. If you think about hallucinogens where they're stimulating your senses, a lot of times a person, or even stimulants like meth and cocaine, the pupils will get a lot bigger. They'll get like saucers. The black part of the eye will take up a lot more. So withdrawal, pretty bad. Withdrawal's not a good thing here. Let's see here. Brittany, do you mind taking us through some of the withdrawal?
Sure. How many do you want me to do?
I'll just do that one side, then I'll pick on somebody else.
Okay. Lack of sleep, increased sensitivity to pain, general malaise, restlessness, craving, sweating, extreme anxiety.
Okay, as a therapist, the thing that I'm worried about there is lack of sleep, because people, when they're coming down, are awake. They're going to do what they can to get more. You don't want to crash. So that's my concern there. The other, like coke and meth, they're eventually going to pass. You're going to sleep. This, you're not going to sleep. You're going to want more. Craving, sweating, extreme anxiety. My life is going to end. This world is going to end. Like you said, there's an amnesia that develops because it's a bad feeling.
Which is probably not made any better by lack of sleep.
No, that's the thing. Nikki, do you mind taking us through the rest of those?
Sure. Fever, chills, increased rate of respiration, including panting, cramping, explosive diarrhea, intense aches and pains.
Yeah, muscle cramping. Imagine somebody just, in a ball on the floor, writhing in pain.
I had a roommate that stayed under his bed for probably a week and a half, going through withdrawals.
Really going through detoxing and withdrawals?
Yeah.
Oh my gosh.
Stayed under his bed.
So the thing of it is, I'm alluding to heroin, but the pills, the over-the-counter, the medicine, not the over-the-counter medicine, but the prescription pain medicines, that detox is horrible, and it takes a long time for people to detox off the pills, especially people that have snorted them or become so, some people take 20, 30 pills a day that have become so dependent and tolerant of them. That detox is a long time and withdrawal. So those folks really do need a structured environment. And that, that's where our state's like. I mean, our state doesn't have very many rehab facilities, and we don't pay for it. So we're not going to have them. And so when people are going back and forth, they're struggling. They're really, really struggling.
We did not get our deposit.
You didn't get what?
We did not get our deposit.
Yeah, this one sounds really fun.
Is heroin like the worst drug to come off of? To withdraw from?
Probably subjectively. I would say subjectively, probably so. Like a person's own rating while they're in it. But as far as dangerous, it's not the most dangerous. I think the one we're going to cover, the second half of class, is the most dangerous. So.
I know they say alcohol withdrawal for the worst, like going through DTs, like people I've talked to who have actually gone through like the hallucinations and the actual DTs of alcohol withdrawal would say that there's nothing more horrifying than that. And I only say that because I've worked with a lot of alcoholics as a pastor and as a counselor that were just like they think spiders and shit are crawling all over their body and literal like full-fledged hallucinations. Sorry, didn't mean to interrupt.
No.
I've had some experience who've gone through it.
I agree with you, and I would say that some
cut off again.
And I would say that somebody's in that sort of state that's going through alcohol DTs where they're shaking. They literally need to be in the ER. They need to be someplace where they're medically supervised.
Xanax.
So that feeling that they have of like bugs crawling and the itching that they do, is that because of the histamine combined with like a hallucination?
Could be. The histamine, yes. They could also have a hallucination.
That's interesting because you hear about people doing that. That's interesting.
You see sores on people that are really.
Oh yeah.
Yep.
Tolerance is rapid and pervasive. Why? Why would you have a rapid tolerance on something that is messing with your pain receptors?
If one's a little, too many's never enough.
Well, let's think about it. If I had a drawer right here and I slam my hand into it, oh, man, would I want to sit there and keep slamming it? Or if I had like a hot plate right here and I said, class, you smell something burning? Joe, our pain receptors are necessary for our survival, and our body is quick to adapt to things that our body needs for its survival. And we need to know if we're getting messed up, if something's hurting us. If we don't know that, our lives are in jeopardy. The hallucinogens are actually a little bit quicker with tolerance, developing a tolerance. It goes probably hallucinogens 1, probably opiates 2. And if you think about hallucinogens and not being able to perceive reality clearly and where the edge of this cliff stops and if you're not able to perceive those things clearly, your life's in jeopardy. So we really get a very quick, even a quicker tolerance with opiates, with hallucinogens. If somebody takes one dose of a hallucinogen one day and then does the exact same dose the next day, they may not feel it at all. Kind of the same is almost true with opiates because you do get a quick tolerance. So dependence, a goal is to avoid negative withdrawal symptoms in the immediate. After a while, it's to need the drug just to feel normal, like meth or cocaine. The brain gets used to it, and my new normal is. I need to feel chilled out with these opiates because I'm just this world really sucks and I don't feel good without it. A bad thing is if you do get hurt and you go to the doctor and you're really tolerant to pain medicines, those pain medicines that they're going to give you are not going to work very much. They're not going to work, and you're going to be feeling some pain. That tolerance that we talked about. Long-term use, again, think about the neural pruning with the dopamine. This is no joke for people that are trying to overcome opioid addiction. those same pathways, those pleasure pathways that we get normal satisfaction and pleasure from eating or socializing or making a little bit of money, or those things that we used to get pleasure from and used to enjoy, they just don't mean that much. They just don't give us that much anymore. So it's a hard thing to overcome. You do get some brain damage. I talked a little bit about chromosome damage last time with the stimulants. So the mechanisms involved down here. You think about breathing, heart rate. The receptors for pain are down here by the brainstem in that midbrain, not so much up here in the cortex. So what are our goals for treatment? Some of these goals is safe detox. And safe detox, get the person away from the environment where they can't get any. They're going to hate you, especially if they weren't ready. But, safe detox is important. Naloxone, we talked a little bit about the, methadone. Naloxone works a lot like methadone, only it's a little bit, it gives a person even less of a high. I had a person on naltrexone, which is down here, coming off of heroin, coming off of pain pills, and it was effective in that if a person takes a dose of this, the naltrexone, the way that they've got it, it's an extended release. Basically, for a month, they can't feel it if they were to take. The problem though is that you can still overdose.
On the naltrexone?
No. If you took heroin and the naltrexone is in your system, you can still overdose.
Yeah, I was going to say there's nothing to stop that. Even though they can't feel it, addicts sometimes don't care, so they still may try and take some out.
That's the bad thing about that. If you look at the side effects, the warnings on the warning label, it's that a person can still overdose pretty easily. It makes overdose more likely in some cases. So
Is that like taking the same amount that they took with the naltrexone?
Yes.
Or is that they're taking more to try to get that desired effect?
It's kind of both. Again, it's the overdose with opiates is tricky because of that. Because of the environment in which a person's used to using. If a person's used to using a certain environment, it takes more. If the first person goes to a novel environment, it's going to wear off. It's those cues like Whitney had mentioned. Medication-assisted treatment. I did have success. I haven't treated a lot of folks outpatient for heroin, but it was a success. It was a long process, though. There were slips, there were relapses, but thinking about the client that used the naltrexone, it was eventually a successful treatment. Buprenorphine is another one. Rehab. What I did a lot with this patient was talk about effective dose and lethal dose, and I think that did have an impact. The person, that I was treating had an understanding, a cognitive understanding of what those things were, and wanted to live. So it's important. Treatment, sometimes if a person is so accustomed to that environment where they used, sometimes getting out and transitional living, getting into a different community is necessary because the triggers are so profound. They're still there. And so sometimes it does take even moving to a transitional living environment away from where they grew up or where they used. Okay, hopefully that made sense. Questions, comments? I wanted to get through 2 of these. That could have been a whole class, but we're trying to go through them pretty quickly. Okay, let's jump into the anxiolytics, sedative. And so, a lot of these are benzodiazepines. So I'll spend a lot of time talking about benzos. What do they give a person Valium and Xanax for? Anxiety. These are commonly used, commonly prescribed medications. Person's having a panic attack. Xanax. You know, the doctor. When a person goes to a doctor, that doctor is looking to give them a solution. And so, a benzo is going to give somebody a short-term solution for panic attacks. Let's see here. Liz, are you still out there, or did she have to take off?
He left, I think.
Okay, I thought so. Let's try Justin. Justin, you mind taking us through tranquilizers or anxiolytics? You don't have to say anxiolytics.
All right. The word lysis means to break down. So, anxiolytic medications break down anxiety. These are commonly used to treat agitation and anxiety. Sedative, hypnotics calm people down by moving them closer to sleep. So a number of these are used as sleeping pills or to aid in going to sleep.
Okay, so you see a lot of these medications in the same class also are sleep aids. They work with primarily a substance in your brain. You recall from our brain lecture, GABA, and GABA is the main inhibitory neurotransmitter in the brain. When it's released, things shut down. So if a person's feeling really anxious and you take a pill that's going to shut some things down, that's a good thing, right? Because if you're really hyped up and your adrenaline's pumping and you're starting to hyperventilate and your body gets a pill that brings that down a little bit, it'll keep people from having that all-out panic attack. And it is fairly effective at giving a ceiling to, the anxiety. However, this is not without its side effects and cost. So there were barbiturates before benzos. See Seconal up there. They're considered central nervous system depressants, as is alcohol.
Isn't that essentially what Bill Cosby's accused of feeding to all of the women he supposedly took advantage of? Is Quaaludes and barbiturates?
I'm not sure. I haven't followed.
I think that's
Bill
what the accusation is that he was feeding, he was telling them that he had some for their headache, and he was giving them barbiturates or Rohypnol, same type of thing.
Rohypnol does cause memory loss. That's been a date rape drug, and that's in this class. It is
Yes.
in this class. It's
Okay.
a benzo.
Sorry to interrupt.
No, that's very relevant. It's an inhibitory neurotransmitter. Phenobarbital is still used for seizure disorders. You just don't see barbiturates prescribed as much anymore. You saw those earlier, like in the 50s. It's like an earlier class of sedative, anxiolytic. Librium, discovered accidentally in 55 and 57. Anyway.
Was it discovered by a woman? It was eventually tested because it had such pretty crystals.
It had such pretty crystals.
I just find that funny.
For a while.
Diazepam,
Once it's
Valium was soon developed and marketed.
in 10 minutes.
Benzos were safer than the barbiturates because a fatal overdose was not very possible. That's not actually. You did see more overdoses on barbiturates. There are limits to its ability to sedate. So barbiturates do a little bit more with your breathing, whereas benzos don't do quite as much. However, with alcohol, it's still possible, so drinking using benzos is not recommended. So that's where you have those additive effects. You take two depressants, one type of depressant, alcohol, another type of depressant, a Xanax, boom, you have more than you planned on because they're doing the same thing. And sometimes, multiplying that effect. So
Not recommended is a pretty mild way of putting it.
Yeah, don't do it. You have Ativan, you have not a trade name, but generic name of lorazepam there. Xanax, generic alprazolam, Xerax, oxazepam. You notice a lot of these PAMs, if you see that, if you see a person's prescribed that when you're looking at, okay, because that's one thing that we should do when we're treating people is get a list of prescription medicines that they're taking. A lot of times, if you have somebody that's treated for substance use disorder, they'll have gone to a doctor to get something, and whether that's a coping mechanism, whether that's drug seeking, that's something for you to discuss with your client, with your patient. Is this something that's helping you function, or is it something that's adding to your dysfunction? And those are, again, doctors are looking to alleviate a problem in front of them. They're not necessarily, in my experience, always looking at an addiction. I think that they're getting better at that because there's more pressure to, but not necessarily. There was a doctor here in town that lost their ability to prescribe opiates about probably 8 years ago now, but literally, people would go to this doctor for that reason because they were going to get an opiate prescription because he was notorious for it. So I won't mention any names, but it happens.
We had a similar situation here in Woodward where a doctor was actually, people were showing up in the ER with respiratory failure, not by abusing anything, but by taking them as he was prescribing them. Like, he was prescribing such high doses that people were having respiratory distress. Just on their taking their medication as prescribed, like multiple people.
Hopefully that person had some accountability for that. Nikki,
he's gone. He's gone. There was a team of doctors that actually filed paperwork on him, the ER docs.
What were you going to say, Nikki?
I read a study. It was from probably about 4 or 5 doctors, and they all said that if somebody called in with the generic name, with like the actual name saying Xanax, then they would automatically tell them no. But if the person called in and said, I want alprazolam, then they'd say, oh, well, this person obviously knows what they're talking about, so we'll go ahead and give it to them.
Like if they called in with the generic name and not the brand name?
Yeah.
Huh. That's interesting.
Because they were like, well, obviously this person knows what they're taking, so it's okay.
Huh. Yeah, it's something to really pay attention to. I mean, if you're going to practice in the field, you're going to be the addiction professional. And if that client is serious about their recovery, they'll sign that consent to release information to their doctor so that you can have a conversation with that doctor or their nurse about what you're working on. That's one of the things in the drug court that we work with here in Garfield County. You have people trying to manipulate the system so that they could still abuse benzos, opiates, whatever it might be. So a doctor is going to be a lot less likely to prescribe a medicine that can be abused to somebody who they know is seeing a substance abuse counselor. So that's my offer of information for practice today is if you do have a client that's got prescriptions, have them fill out a confidential release of information. You'll see how serious they are about their recovery. Because if they're reticent or they hesitate, I don't know. It doesn't seem like you want to stop using this. It seems like you might be dependent on this, and that's where you get into that conversation. Halcyon, Ristoril, Rohypnol. There we discussed. Again, that has a reputation for really wiping out memory. Here it talks a little bit more about being a date rape drug. There is a current trend, so BZ stands for benzos. There is a current trend toward less use of benzos for treating anxiety with the development of several other classes of drugs that can enhance sleep or reduce anxiety, including Ambien. However, Ambien still has a potential for abuse and still has the same side effects as most benzos. It's not a miracle drug. And you still have people struggling to get off of it. If you have a drug that causes sleep, somnolence, what would be, because that's what you're like when you're taking the drug. What's the withdrawal like for a drug that caused you to sleep? You're awake and you can't sleep. And another effect of that drug was anti-anxiety. So you're awake, and what else?
You're anxious.
And you're anxious at 3 in the morning. I've worked with several people that have been prescribed benzos, Ambien, Valium, Xanax. That's one of the primary complaints is I just can't sleep. I've got to be able to sleep. And feeling dragged down and strung out. I mean, maybe not strung out, but just feeling bad. Especially waking up at 4 in the morning and then can't sleep the rest of the day. Their day starts now at 4 a.m. If people can avoid taking these, please do so at all costs. The short-term gain is, in my experience, is not worth the long-term risk. With these, and people are like, but I need it for my anxiety. I haven't seen that many people successfully navigate not becoming dependent on it. Maybe my perspective is skewed because I'm a substance abuse counselor, but it's a tough thing to stop once you start down that trail because you're awake, because you're anxious, because the substance stays in your system 14 days. It gets into your the plasma in your blood, and you don't eliminate it as quickly as a lot of these other substances. Like alcohol is gone the next day. Not as Xanax. That's in your system for a week or longer. So again, these are difficult things. Benzos, they do have less suppression of heart rate, although a person can still overdose and get a significant tolerance as well. People have decreased REM sleep when they're taking it, and then when they stop taking it, boom, they have all kinds of dreams. They have these vivid, lucid, like they're awake and they think that things are happening, and so their brain is trying to recover from this reduced REM sleep, and so then you have restlessness and wakefulness throughout the night, and that can last several weeks. That can last past a month. The explosion of dreams. And they're usually not good ones. They're usually because the drug's already out of your system and you're feeling anxious now. Benzos decrease the amount of time in REM sleep, and so when one goes off, so your quality of sleep, your body and brain really need that REM, that dreaming sleep, or else you don't get a good quality of sleep. You don't feel rested. So a lot of times people will wake up and they may have slept 8 or 9 hours after taking an Ambien or Benzo, and they're like, oh. No, they're still not. They're not rested. A lot of research now coming out really looks at the effects on memory. There is a very clear effect on memory. There's also a lot of studies published now that have effect on cognition, where people actually have some cognitive slippage after staying on for over 90 days. You see people's IQ actually dropping. Their ability to cognitively function. This may persist for several months after the drug is discontinued. So again, this has to be weighed out. I would not recommend anybody take a benzo over 90 days. Period. With repeated use, tolerance increases as benzos become less effective in enhancing GABA. In other words, your body's natural inhibitory self-calming ability, it takes that away with the tolerance. All benzos become less effective in reducing anxiety in as little as 4 weeks. I'd say probably a little faster. And in order to get the same effect, one may take larger and larger dosage. By definition, rebound effects are the ones that you get when you're trying to treat in the first place. So if you were anxious going in and you took some benzos to get rid of that anxiety, there's a chance that that could rebound up even higher, that your anxiety could be higher than it was before you started taking them.
From a purely cynical point of view, that is something that pharmaceutical companies don't mind at all, because that means that you need to keep taking them forever.
Well, I'm not going to comment on that one, but I'm just...
You've dealt with this enough to be as cynical as I am.
My main thing is that if people are... I see cases where people need something for anxiety immediately, where they're in panic, where there's been a horrible thing happen, and these drugs are very effective at creating a ceiling where a person is not going to experience a debilitating amount of anxiety. The problem with
panic attack. I've seen people with panic attacks who literally like freeze and can't breathe or drive, or I mean, like in the middle of driving, like they freak out, and that's real life. That's
the problem being is that if you have that. If you continue to take something like that, it's not going to make your life better.
Nope.
Here's this guy. One does not simply stop taking benzos. True story. These can be medically dangerous detoxes. Your heart, over 100 beats per minute for a prolonged amount of time. Typically, if people, I had a person that I was treating that would go into seizures. That is one of the side effects, because they're taking so many benzos, and so it's important to step these things down. It's not something where if a person's used to taking a bar or 2 bars a day, Xanax can just stop. That's not recommended. Please. So if you're a professional and you're treating somebody that's on a high dosage of benzos, please see them through. See them 2 or 3 times a week. Help them step that down with a nurse, with a doctor. Help them step that dosage down. Get them some help. So here's the higher dosage. You can have tremors, anxiety, insomnia, nausea, seizures, and you can have grand mal seizures and even cause death. I mean, coming off of this. Rapid pulse. You can have depression. May cause dependence. It does cause dependence. So here's where you're intoxicated up here. It does cause nystagmus. So if you have a sobriety check and your eyes are real jerky trying to follow a light, that's one of the sobriety checks that police officers will do for impaired driving. And it will impair your ability to drive, much like alcohol. And then, so here's your withdrawal. And so I think that we'll stop there. Don't worry about the rest of that PowerPoint. We won't include that on the test. So a good stopping place would be the intoxication and the withdrawal. So next time we'll go into the impact of trauma, and then we're going to get into our Di Clemente book. So just a refresher, kind of remember that we have this book floating out there, and you should have it in your possession. I do have an extra copy if anybody wants to borrow it. Otherwise, I'll see you Wednesday. I'll see you Wednesday. Okay, take care, everybody.
Thank you.
Thank you.